Okay. So Will has a background in anthropology, urban planning, and education. He has been a teacher, adjunct, school administrator, entrepreneur, game designer, and disability advocate. He now works for Disability Network, Washtenaw, Monroe, Livingston, as Director of Accessibility and Education, leading collaborations to build community accessibility solutions and programs. Please join me in welcoming Will Purvis. Will, I will pop your slides up and you just let me know when you'd like for me to move forward or backward, okay?
Yeah, this is Will. Thank you so much, India, for the introduction and welcome everyone. Um, so this is the first of 4 workshops aimed at uh, the grant recipients. And we have, in talking about the structure of the workshops and flow of the workshops, we thought it might be a good idea for this first one to be sort of a level set. So it's going to be more general in terms of sort of what the ADA, the American with Disabilities Act, means for medical and dental clinics. Some of you, I'm sure, will be well versed in some of this. Others, this may be relatively new. So if you have questions along the way, please either pop them in the chat. We'll stop a couple times to see if there are any questions, but it should take about a half an hour. So we should have folks, we're scheduled until 12:45. So we should have, we might have a little bit of time for questions at the end, but if there are burning questions, please don't hesitate to, like I said, to put them in the chat or save them um, for those stops. India will be reading the chat to me. I have a visual impairment, so it's not as easily accessible to me. So without further ado, so this is just starting with a photo of our staff recently, and you can go on to the next slide. India. So our mission, the Disability Network, Washtenaw, Monroe, Livingston, is to empower the lives of people with disabilities and advocate for a more inclusive community for all. We are one of 13 disability networks. We have various names across the state of Michigan. There are other similar, we are all centers for independent living, and there are other similar centers for independent living in other states across the country. We receive both federal and state funding. We also do some of our own fundraising as well. So at the next slide, this is where we're going today. So a little bit about who we are and what we do, the Disability Network, and then a brief sort of how we think about accessibility and disability, and then moving into a couple different um, aspects of the ADA. First are sort of major implications for medical and dental clinics, then some common access issues, then some general strategies, and then sort of some spoilers for where we're going next in the workshop series. Next slide, please. So as a Center for Independent Living, Disability Network provides a wide variety of services. And the Disability Network, we're divided into geographically across the state of Michigan. If you are not familiar with the Disability Network in your area, please don't hesitate to reach out to me. I can refer you to ones that are specific to your county. I know some of you are already working with disability networks in your area on aspects of this project, and we are all excited to be partners in this program in various ways. I'm not going to go into detail about the various kinds of services and support and programs that we offer, but there are a wide variety of them. We have a staff of about 30 people across the 3 counties that we serve. Next slide, please. So, just so that we're on the, like I said, on the same page, the American with Disabilities Act, sort of the basic definition of a disability is a physical or mental impairment that substantially limits one or more major life activity. If you qualify or feel you have a disability, there are a variety of different ways to receive accommodations, which an accommodation is sort of at its basic level is a modification or adjustment to a job, the work environment, or the way things are usually done. If you are in a school setting, these are generally defined under statutes, federal and state, through an individual education plan or 504. In the workplace and government, these are defined also by statute, but also by HR or other policies and procedures as they interpret them for you. There are also architectural standards, all sorts of other things that have implications as well, which we'll get into. Next slide. So we tend to find, in terms of our work on accessibility, we tend to focus on sort of general kinds of disabilities, and these are not exclusive categories. They are often overlapping categories. Many people, in fact, most of the people that we serve, the 3,000 or 4,000 people per year, have list multiple disabilities. And so we find that when thinking about accessibility work and access to services and to facilities, especially in this case, medical and dental clinics and practices, thinking about sort of through a lens of what these sort of kinds of disabilities are can be helpful in sort of you all and us kind of brainstorming and figuring out sort of where the barriers might be to services that you're providing, to medical equipment, to parking, to restrooms, websites, etc. So as you're going forward in this your sort of accessibility your accessibility journey, having a sort of an eye on the various kinds of things that might people might come to you with and that might present barriers to services is a useful way to kind of think about things. And for many of the folks that we work with on accessibility issues, sort of running through this as sort of a checklist as you're thinking of new programs, as you're thinking of purchasing new equipment, as remodeling and so forth. Sort of how does this affect someone? If someone had a speech impairment, how would this look when they came in, or if they were a staff member at our facility? So feel free to reach out. I think we talked about this when I visited the group in June. We are always available, so are other disability networks, to talk through and work out specific kinds or general kinds of accessibility issues. So feel free to give us a call. Next slide. All right, so we're moving into the major implications. Are there any questions about anything that I've talked about so far, or anything in the chat, India?
Nothing in the chat right now.
Okay.
If someone would like to speak, I'm happy to unmute you. You can just raise your hand and let us know. All right, I think we can move forward.
All right, next slide. All right, so in general, the implications, the Americans with Disability Act, the ADA, it's a civil rights law. It has a long history of development, and then since it was passed in 1990, 35 years of changes and amendments and statutes and interpretations. So it's a big thing. And in general, though, it prohibits discrimination against individuals with disabilities in all areas of public life, including public accommodations. And its implications are broad and they are legally binding. Next slide, please. So there are a couple different things that it sort of sub areas of implication. One is equal access to services. So specifically to clinics, that the ADA mandates that you must provide individuals with disabilities the same level of service and care as you all extend to other patients. This means no denial of service based on disability. It also means that reasonable modifications of policies, practices, and procedures. So you're required to make adjustments to your established ways of operating to ensure access for people with disabilities. The key word there oftentimes is reasonable. And so there's a couple different examples there. So allowing a patient with anxiety have an early appointment to minimize noise and people, permitting an aide or companion to assist a patient during an X-ray or scan, or reading paperwork aloud for a patient who is blind or has low vision. So those are sort of reasonable modifications that you could extend to people with disabilities. Next slide, please. The next thing is effective communication. Clinics must ensure that communication is easy to understand for each patient, regardless of their disability. This can involve providing qualified sign language interpreters for deaf or hard of hearing patients, using clear, simple language and visual aids for patients with cognitive disabilities, offering information in large print or braille for visually impaired patients, utilizing augmented and alternative communication, AAC devices or apps for patients with speech impairments. Next slide, please. And then probably the most significant and most well-known sort of section of the ADA is providing accessible facilities and equipment. And this includes a number of different things, and they're on the following slides because there were so many of them. So next slide, please. All right, so accessible parking and entrances. So designated accessible parking spaces, ramps, wider doors. And this is where sort of the recommendation and the statute sort of then extends into sort of what works for more people. So this is a good point I find often to kind of look at the ADA as sort of the minimum. It's the floor, and then you're sort of building on top of that in terms of your accessibility. So the ADA mandates 32 inches clear opening. We recommend a minimum of 36. Many people recommend a much wider opening for doorways and automatic door openers. Clear pathways and hallways, accessible routes at least 36 inches wide, free of obstacles, stable, firm, and slip resistant. Again, we recommend wider, accessible restrooms, at least one restroom with grab bars, accessible sink, raised toilet seats, and sufficient maneuvering space for wheelchairs. So one of the things too that we'll be getting into later in the workshop series is thinking about these kinds of accessible facilities and equipment for the patients that you serve, your clients, and also for the staff and of your clinics, so that thinking about accessibility globally and holistically for your organization, and not just for the folks that are coming through the door. So next slide, please. So the next sort of continuing that list, accessible examination rooms. So having clear pathways, entry doors meeting those width requirements, and clear floor and turning space within the rooms, like um, uh, the ability to reposition furniture is often highly useful in this situation. Then accessible medical equipment, so adjustable exam tables and chairs. You must be able to lower to wheelchair seat height, so 17 or 19 inches above the floor, and have features and removable adjustable support rails, clear floor space for wheelchair maneuvering. Another example would be wheelchair accessible scales. Um, and other accessible imaging machines that can adjust the height for those folks using different kinds of mobility devices. Next slide, please. And then, although it doesn't, the website accessibility also, I know some folks in this group are working on updating your website. So the general interpretation is that businesses covered by Title III, like healthcare clinics, should strive to make their websites accessible. And this means adhering to the web content accessibility guidelines. And I'm sure some of you, especially on the administrative and the IT side, have heard about the WCAG 2.0 guidelines. I know enough about this to get myself to know that I shouldn't be talking in any depth about it. So I'm happy to provide references. I can talk about this generally. There are a number of folks around the state, are other especially a couple other disability networks who are have staff members who are taking a really deep dive into this. And as a network across the state, we have some of us specialize in some things and others specialize in other things. So this is an area where our network itself hasn't spent invested a huge amount of resources. Others definitely have, and we can support and offer guidance on this as well as you move forward with your upgrades. Next slide, please. All right. So before we move into common accessibility issues, are there any questions?
We do not have any questions in the chat. Would anyone like to be unmuted to ask any questions to Will? All right, I think we can move forward.
All right. Next slide then. Okay, so common access issues. So typically we see the following kinds of things. So the first would be sort of in the category of physical barriers. So inaccessible entrances and exits. So a lack of ramps, narrow doorways, absence of automatic door openers, and tight spaces. So not enough maneuvering room in waiting areas, hallways, and examination rooms. This is probably the biggest concern or complaint that we get as a network for accessibility issues, not in general, not with relationship to clinics in particular, but looking at sort of how traffic flow might move through your space and looking at how much furniture you have. And the answer is often too much. So thinking about that and thinking about that maneuvering as you're looking at your space. Inaccessible restrooms. So again, the lack of grab bars, the insufficient clear floor space, so that rotation and maneuvering room within restrooms is very important. and having non-adjustable equipment, so exam tables, dental chairs, scales that are fixed, that are difficult, or that can make a transfer from one to the other more risky or hazardous than it needs to be. Then high counters. This is often the case at reception desks or check-in counters. So for folks who are in wheelchairs, they are often or can be below the height of those counters. So checking those out, making sure that those are a good height for the people that are coming into your facility. Next slide, please. So communication barriers is the other area of um, an access barrier. So a lack of qualified interpreters. So sign language interpreters for deaf patients or language interpreters for non-English speaking patients. So thinking through how you access those folks, whether you have them on hand, whether you know ahead of time whether someone will need that interpreter. Those are all questions that can lower that barrier. Insufficient alternative formats is often a barrier, so not providing information in large print, in Braille, or easy to read formats for patients with visual or cognitive impairments. Staff training. So we talk a lot with folks about being trained in effective communication strategies for patients with various disabilities, especially things like not speaking clearly for hard of hearing patients or patients with cognitive challenges. And then again, website inaccessibility. So websites that are not navigable by screen readers or they lack proper alt text for images. So alt text is a hidden coded description of an image that a screen reader will pick up, or oftentimes now AI or PDF readers will pick up the alt text when it's reading a document to someone with a visual impairment. And so if you're relying on images to convey information about a procedure or a practice or a policy, then having that alt text in there is critical for complete understanding, and or if it's incomplete, for the patients and users to be able to ask questions. Next slide, please. Then logistical and other challenges. So transportation. So patients with disabilities often face significant hurdles in arranging accessible transportation to and from appointments. And this doesn't necessarily imply, and I'm not saying you have to provide this as a clinic, but if someone can't get to you, then sort of troubleshooting and working with that patient in order to facilitate them getting the care that they need and deserve is something that you might have to work with. So talking with staff, working with local agencies and other support folk in order to facilitate that transportation can be helpful. Scheduling difficulties. So oftentimes longer appointment times for patients who require more assistance or time for communication. So thinking about how do you build that into scheduling can be important. And that's going to be oftentimes there's going to be a dance between sort of what you're sort of allowed for and what you might need. So how do you navigate that? That terrain is something that a conversation that would need to take place in order to provide more accessible services. Attitudinal barriers, and these may not, as it says here, these may not be something that's out in the open all the time, but some folks may lack experience or comfort in treating patients with disabilities, which might lead to discomfort, miscommunication, or sometimes discrimination. And then the lack of specialized equipment. So as I said before, you may, as a clinic, meet those basic ADA standards, but you might lack specialized equipment that might make it possible for you to easily treat or address complex cases. And so sort of thinking about those, how might you treat, who are your partners, who are your collaborators? And I know that some of you are working on sort of expanding the range of offerings and types of clinics and facilities so that you can sort of broaden the circle of folks that you treat. And so as clinics who do serve those kinds of patients, then expanding your network so that other people and clinics know that they can reach out and coordinate care with you might be something to increase access overall. Next slide, please. Any questions about any of that before we go on to some sort of general access strategies?
No questions in the chat. I will say we have about 10 minutes left in our
Yep.
presentation. We don't have any questions in the chat if you want to
Okay.
take over.
So some uh, general strategies for increasing access. So sort of the layout, sort of the physical layout of a clinic. So there's lots of talk, and I'm sure that some of you have attended workshops and heard sort of the phrase universal design. We like the sort of ideal of universal design, but we realize also that it is a really lofty goal. And so we tend to work and support folks in sort of making uh, changes as they reach towards that goal. Not reaching that goal can require it requires resources, time, and organizational and uh, leadership support. So having sort of starting on that road is something that's important, but realizing at the beginning that it's going to be a journey, and it's going to be probably more about the journey than it is about getting there all the way there, whatever that might mean. So one of the things to think about is sort of proactive accessibility. So if you have the luxury of a new space, so sort of you're designing a new clinic or a new wing or a new room, sort of thinking about accessibility in that space from day one, rather than sort of adding those accessibility features as an afterthought. So it often is cheaper to do it initially and think through those accessibility issues first than it is to retrofit them in later. So spending some time with folks who think about accessibility, whether it's architects, whether it's folks from myself or other people from Disability Network or other disability advocates, sort of we spend a lot of time going over site plans and room plans and design features and things like that as new facilities are built in order to sort of think through what might be sort of the best ways to use this space, what might be useful ways of putting the pieces together. The next thing to think about is height adjustable everything. So beyond, like I said before, the exam tables, this can include reception counters, sinks, imaging equipment, desks, and so forth. So a lot of times what we talk with folks about is that as you're thinking about accessibility going forward and improving accessibility, someone in your organization probably has or should have some sort of purchasing plan. So when this set of furniture or this set of equipment is no longer functional or useful, then we're going to get new equipment. So to build into those plans, to build sort of an accessibility sort of checklist is often a really useful thing. So as we're replacing X, then the next one we get is going to be accessible. So that helps with financial planning, especially because some kinds of accessibility upgrades, like we talked about before, can be very expensive. So if you're building that into your budget and long-range forecasts, it often becomes easier to build in and think about accessibility improvements than it might be to sort of look around and go, oh my gosh, what are we going to do? The next thing on here, thinking about sensory-friendly environments. I know some of you are already doing this, and that's great. Uh, Integrated patient lift systems, again, more high-priced item, but also they can be more easily integrated into exam rooms and support your staff as well as your patients. Next slide, please.
Well, we have about 5 minutes left in the presentation.
And I think I'm almost done.
Okay.
So, yep. So, so telehealth and virtual tools. I know some of you are already doing this, and many of you probably are already doing this already. So they can reduce transportation barriers. They increase flexibility for patients and staff. And they also can, especially as we move forward technologically, integrate with remote monitoring and wearable devices. Um, uh, Again, thinking about augmented and alternative communication tools, so voice generating apps and integrated communication platforms also fit into this category of digital tools. Next slide, please. And then the staff training. So starting to do that here, but there are many, many other options. So thinking about scenario-based training, we really like scenarios based on common experiences to train staff. And then also thinking about trainings that focus on empathy and patient-centered care, which I'm sure some of you or many of you are already doing. So how do you foster that culture and ensure that staff understand the unique needs and perspectives of patients with disabilities? Next slide. And then I'll just jump into the last slide here. So this is where we're going in the next workshop. So thinking about sort of other things. So training staff, sensory-friendly environments, specialized equipment, all of those things that we were talking about. How do we sort of move forward with those for both staff and for patients, for workflow, and I really look forward to talking about all of that with you. If there are any questions, I think we have a minute or two left.
Absolutely. Um, Thank you very much, Will. Would anyone like to ask a question before we hop off? We do have a few minutes, and I can make myself available, and I think maybe Will has a minute to spare. Question.
Yes, I can stay on. Happy to stay on if people have questions.
You can feel free to unmute yourself and just jump right in. All right. Well, I do have a comment. Again, thank you very much for this. I work in disability and health, but I do appreciate the new information as well as the reminders. I was thinking about the scheduling, and one of the things that the center does is when we work with our partners who have spinal cord injury or more severe physical disabilities, we aim to not have meetings and activities early in the morning. It can often be a challenge for individuals to get their day started. So I just ask that you all keep that in mind, and integrate that into your flow as you can. Um, I would also like to ask, if you have not completed your video consent form, please do so and email that back to me. Michigan Medicine requires this form being completed, because we would like to have these videos edited and, I guess, professionally compiled to be used for trainings in the future. Does anyone have any final thoughts? Kim?
I'm here just trying to get to the unmute. That was great. That was so much new information. So thank you, Will. The question I'm wondering is where to start, but I'm sure we'll get to that in some of the sessions coming up. So thank you so much. This is brilliant.
Wonderful. Well, again, we will end on time. Thank you all, the grantees. I appreciate you attending. I appreciate you inviting others to join us. And we look forward to our next workshop. In the meantime, feel free to email me and I'd be happy to connect you with Will. If you have any financial questions regarding the contracts that are slowly but surely on their way, feel free to contact me and I can connect you with Chrissy. Thanks, everyone. And thank you, Will.
You're
Appreciate
welcome.
it.
Thank you for facilitating.
Wonderful. Have a great afternoon, everyone.